Hi, Unni. It's a pleasure to welcome you. You and I first connected through our shared affiliation with the Norwegian Institute of Public Health, where you've worked for over 7 years and are now a senior scientist, and where I was a Fulbright scholar starting in 2023. Your career has spanned clinical medicine, health policy, and global governance, um, beginning with your early medical training and research in Norway through your own Fulbright Harkness Fellowship at Harvard in 2018 to 2019, and now as a senior scientist at the Norwegian Institute of Public Health. Over the years, you've worked on topics ranging from antibiotic resistance, equitable access to medicines, tobacco control, health financing, pandemic preparedness, and evidence-informed policymaking across regions as diverse as East Africa, the United States, and Scandinavia. Your experience offers a unique perspective on how evidence, innovation, and collaboration can drive fairer and more effective global health systems. I'm really looking forward to learning more about your journey and perspectives today.
Thank you for having me and the kind invitation, and I look forward to this conversation.
Great. So my first question for you is about global pathways. You've worked with academic institutions on health systems and public health questions across very different settings: Norway, Myanmar, the United States, Ghana, and Kenya over the past decade. How have these experiences, from researching tobacco control in Myanmar through completing the Fulbright Harkness Fellowship at Harvard to working at the Norwegian Institute of Public Health, shaped your understanding of what global health means in practice?
Thank you for that question. So when I first encountered the field of global health, which was in medical school, I think then it was also described as international health or tropical medicine. And this was kind of mid-2000s. And a lot of the conversation was really around the health problems of the poorest countries, which I think still remains as important. Obviously, there are countries that still have high child and maternal mortality, or grapple with the burden of diseases like HIV/AIDS, malaria, tobacco, or tropical diseases, and they continue to dominate. And it's reasonable that some of our efforts in global health is dedicated to kind of contributing to addressing those issues. But I think for me, global health, building on this experience from different settings, has become less about thinking about issues happening elsewhere to kind of really honing in on the issues that are kind of universal in nature and can potentially affect everyone. So you mentioned antimicrobial resistance, which is obviously an universal challenge. And similarly, every setting, every place I visited or worked with have or grapple with the question around equity, that there are certain parts of the population that experience some form of social or economic or geographic disadvantage. That's happening here in Norway, that's obviously happening in the US, and also even the poorest countries, there are inequities, differences between people who have resources, people who have less access to resources. And also issues like the influence of transnational tobacco companies or food companies that influence diets. They also have, to some extent, create kind of universal challenges that needs some form of policy response that we can learn from each other on, regardless of which country you have. Obviously, some countries have more resources to address those issues, but I think still these are examples of global health in practice being a lot also about issues that we all face together. And the recent COVID-19 pandemic obviously underscores, I think, that point. So for me, that's been the motivation, I think, in entering the field of global health, that there are certain issues that also requires a kind of global response because it affects everyone.
Yeah, thank you. I think I differently learned global health, not as international health in the way you're saying. I learned it more just about the countries that had the lowest GDPs or the most poverty in different measurements. And last semester in this class that I teach global health, I had a small assignment where I asked students to compare two countries on a certain health issue and different aspects of it. And I was surprised what kind of countries they chose for comparisons, like comparing Iceland and Indonesia, or Turkey and the Dominican Republic. Not countries necessarily in the same region, not countries of the same economic level. And I think they made for very interesting comparisons. Maybe not very useful, but as an exercise, it really made me question like how countries are grouped in global south terms or global north, which I always want to challenge and don't find to be sometimes the most like respectful language. And so I liked that the students didn't come with assumptions of what it meant to study global health and what countries were included in that. So that's interesting. Yeah. Well, you mentioned your work in antibiotic resistance, and that is as important as ever. So my next question for you is about that. In 2014, you helped write a Chatham House report proposing new ways to fund the research and development of new antibiotics. Why do you think antimicrobial resistance remains such a difficult global challenge today, from when you wrote that report in 2014 and from before? And what have you learned about how countries with fewer resources can still make progress on antimicrobial resistance?
Yeah, so like mentioned, antibiotic resistance is really one of those unifying shared challenges that we all face. And even though to some extent resistance is a bigger problem in some settings, we share that challenge because resistance can travel across national boundaries and borders. And I think one reason why it's a difficult challenge to tackle head on is that it's kind of slowly evolving, difficult to notice in the day-to-day. Other issues kind of gain global attention very quickly. You know, a pandemic, obvious example, but and more recently, other types of crises, like armed conflicts and financial issues. So antibiotic resistance, by its kind of slowly evolving nature, it's hard to maintain attention for it. And second, I think challenge is that it kind of requires effort from all of us. Like a few countries can't come together and say that now we want to solve issue of antibiotic resistance, so let's do it. Like that can happen to some extent for some other health issues. Like countries, a smaller group of countries have come together and said, let's get, make progress on vaccines and develop this what we call the Gavi Alliance to really fund the rollout of vaccines in lower middle income countries. But for antibiotic resistance, we really need a more kind of global, shared, collective effort. And you mentioned the report, which was about how to finance new antimicrobials. So, because all of us, I think, over the next, decades, as the current kind of the current set of antibiotics that we have access to now, they might not be as effective as they are now in the future, and some of them are not so useful anymore. Like for a condition like gonorrhea, there are becoming fewer and fewer treatment options that are effective because of resistance. So we need new antibiotics in the pipeline, and that's a very hard challenge for a few countries to solve on their own. Like you need resources, and you need to motivate industry to invest in antimicrobials, and at the same time you want these antimicrobials not to be used that much. So on one hand, you want innovation, but once we get them, we want to use them sparingly, which isn't a really good incentive for those who want to bring new products to markets. So that's also that's a specific challenge for the innovation of antimicrobials. And then lower middle income countries, I think, also face a dual challenge in that, because many countries, there are still children who don't have access to antibiotics when they get pneumonia, and a lot of children die because of lack of access to effective antibiotics for that condition. So on one hand, you have increasing resistance levels, on the other hand, an access issue, an access problem at the same time. And those things are also hard to reconcile. Just to give an example, which is kind of maybe a bit controversial, but for example, we know that antibiotics can be accessed over the counter in many countries, and that's largely framed as a big problem because it kind of creates the uninterrupted supply of antibiotics. People might use them when they don't need it, and that over time contributes to increased resistance. At the same time, there are many settings where it might be hard to get access to a health worker that can provide antibiotics, and this might be, in some areas, the best way to actually get antibiotics when you need it. So completely getting rid of over-the-counter access might not necessarily be the best policy solution in some settings. Just to give an example, obviously there are a lot of issues around that perhaps a bit beyond the scope of our conversation, but that just in response to your question, just to highlight why antibiotic resistance is an issue that's hard to address globally. With respect to whether countries with less... Yeah, please. Yeah, sure.
Yeah, I think that's really interesting what you said. I want to hear everything else you have to say, but when I was doing my PhD research on refugees from Ukraine who had gone to all different countries, mostly around Europe, also US, even Mexico, that was something I kept running into, is people were frustrated with the different barriers to accessing medicines, not just antibiotics, but other prescription requiring medicines, because those barriers are a lot lower in Ukraine, and people really, everyone I spoke to really loved their Ukrainian medical system. So they found this to be, even though all these countries provide this, a lot of countries provided great support for the Ukrainian refugees and healthcare and all this stuff, people just wanted to go, they missed their Ukrainian healthcare system and that ease of access. And like you were saying, exactly, like in some places it is better, and there's not like a universal necessarily best way, exact same way for everything, including the distribution of commodities and medicines. So that's really interesting to think about, and good for global health students to think about when you tailor and contextualize all programs for each place and context that and people they're meant to serve. So for such an important topic, that's an interesting application of the concept.
Yeah. So we're just going to add that I definitely think every country can make progress, and there was a period where this gained a lot of attention, and the World Health Organization promoted the development of global action plans, and many countries have produced such plans, and there are things going on. But one also has to recognize that antibiotic resistance, and perhaps that's another reason why it's so hard to address that. It's I think previously framed as kind of a healthcare system challenge, which actually maybe should be construed as kind of a social challenge, a societal challenge, and it's also linked to the use in veterinary medicine and animal husbandry. So it's kind of that's when you bring in the kind of wider One Health perspective on the issue, which also makes it more challenging, because then you need kind of collaboration across sectors, and maybe you still concerned about this, but that's always makes a health issue harder to solve when you need involvement of multiple sectors, and in this case, environment, animal health. So yeah, just a few reasons why antibiotic resistance is a important global health policy challenge, but difficult. But we need more people to devote attention to it. So yeah.
Yeah. And for the students or others watching, the One Health is a really interesting program, and we have a big department at University of Tennessee that does that works on that. So I will link that below the video. And just one more question about this, Unni. So you mentioned, you started talking about how like because of the different aspects of antimicrobial resistance not being sort of immediate and interfaces in the same way conflicts and pandemics are, it's difficult maybe to garner attention. Could you just say something for people who don't know why attention is important in terms of getting funding?
Yeah, I'm not sure I have a solid response, but I think it is the case that if I think from a kind of a policy or decision-making perspective, that there are certain things that garner attention more quickly, and it's if the kind of the challenge has kind of very big and obvious financial impact, or is at a scale where you can show decisiveness, and those are also issues that often get attention from funders, and
policymakers too, like you said. Yeah.
But I think it's on us as working public health to not kind of be totally driven by what policymakers necessarily think are the most prominent issues right now. I think because you need a set of people in society that are equipped to think kind of over the long term and across political cycles, and I think that's one thing that's integral to public health, to think kind of over decades and not just in short-term cycles, and kind of maintain focus on those issues that might not be in the spotlight now, but someone needs to keep working on them when they become a bigger problem than they are now. Antibiotic resistance is a big problem, and it's only going to grow. So yeah, I'm not sure that was the effective reply.
No, that was great. Sure. I think that's really important for students to think long term. Maybe we'll mention that or talk about that again when I ask you about what skills students should focus on. But the next question I have for you is actually about pandemic preparedness. So let's take a step back from that long term. Well, preparedness is also long term, but so my question for you is, you were involved in the first year of the Coalition for Epidemic Preparedness Innovations, CEPI, CEPI, which launched in 2016. So what did that experience teach you about how global partnerships can respond more effectively and equitably to future epidemics?
Yeah, so just to give some background for the students who might not be aware what CEPI is and how it came about. So in between 2014 and early 2016, there was quite a big Ebola outbreak, mainly in Guinea, Sierra Leone, and Liberia. It was known as the West African Ebola outbreak. And it was also the first outbreak where health workers who were from high-income countries and were serving in these settings, some of them got infected and were transported back. So also there were Ebola cases in high-income settings that were treated in hospitals. And during that epidemic, there was a large international collaboration that managed to develop an effective Ebola vaccine. It was a vaccine trial in Guinea. Actually, Norwegian Institute of Public Health was actually a key partner in that effort. And one thing I learned is that that vaccine trial could have probably been rolled out much sooner if one had been prepared to do so in advance. And that motivated the establishment of CEPI, or the Coalition for Epidemic Preparedness Innovations, which is working on bringing vaccine candidates or promising vaccines to development, testing whether they're safe in humans, and testing whether they trigger an immune response, and making them ready to be tested on patients during an actual epidemic. So these are vaccines that target diseases that kind of suddenly appear. We call them kind of emerging infectious diseases, and most often in lower middle income countries. So that's the role of CEPI, and the reason why, that's an example of why a global partnership can be maybe a more effective and even equitable response is because these kinds of infections don't really get much attention from the private market or pharmaceutical companies because
They don't make money.
They come in short waves, affect relatively few people, so it's hard to kind of get a return on investment. And they're also very hard to test because once an outbreak starts, you might actually not have enough patients or people affected to actually do a trial that gives you conclusive results. So in order to actually address that, a global partnership can be more effective because if you have countries bringing resources together and you have kind of an organization that recruits and bring expertise together and kind of you get some kind of collective thinking, you get an institution that helps serve everyone. So these vaccines that CEPI develops potentially can benefit all of us. And CEPI also invested in vaccines during the COVID pandemic and have brought several other vaccines forward since then. So it could be an interesting case for students to explore in terms of, if you want to look at what is the value of a global partnership. I think CEPI is quite a nice example of that.
And something I want to mention that I heard you were talking about how the preparedness with CEPI was at least partially focused on developing the vaccine. But I was also thinking that there's other aspects of preparedness that are maybe equally important, such as supply chain strengthening and other kinds of partnerships. I spent this last year working on a paper on postpartum hemorrhage commodities, and I never worked or been exposed to the commodities side of things or all those things that come with it, supply chain, getting it to country, manufacturing, and then policy and regulation that allows medicines and commodities to be accessible in the country and accessible to people. So thinking about preparedness and CEPI creating a vaccine, I feel like that's obviously wonderful, but it's one of the many steps required to really be ready to roll something out. So I want to just bring some awareness for people listening that I think that there is sometimes an assumption that the medicine, the doctor is all that you need, but public health is about the whole system to make it happen.
Yeah, so definitely. And just to add one thing, a supply chain actually has been an area that's been was heavily financed by USAID in many settings, and after the kind of disruption or discontinuation of USAID, that funding has been pulled, and a lot of functions have been. I think some countries have managed to absorb some of those functions, and some countries those functions were done by, I think, private contractors and kind of fell away and not being a part of the kind of public system. So that's, I think it's important part of pandemic preparedness, this supply chain and kind of securing access to commodities, which maybe has been ignored a bit. So yeah, another case for students to look at.
Yeah, I will. I learned a lot, so I'm going to be sharing that with my students. So my next question for you, moving forward, everything you're saying is really wonderful. Thank you. My next question for you is about health systems and equity. So during your 2018 to 2019 Fulbright Fellowship at Harvard, you explored how U.S. health insurance models affect the utilization of healthcare and health outcomes. What stood out to you about how financing systems influence prevention and access to care for different populations? And I want to just add to this, in Norway, there's universal healthcare. And in the US, we have very, very different systems of health insurance. So I think it's fascinating that you came to the US to study this. It's almost like a reverse of what I would expect.
Yeah. So there are different motivations for coming to the US. One is to gain, be exposed to different system and also been kind of interested in the US health policy landscape and everything that's been happening after the Affordable Care Act was enacted, and also to kind of do research in a different country and setting, and so there are different motivations. Sorry, US is quite interesting in the sense that, like you said, it's not a universal healthcare system. But there are elements of universality in some settings. There are states that have a relatively large coverage of their population, and there are so many different healthcare systems in the US that there's a lot of kind of opportunities to learn by comparing and learning from differences between states. So it's kind of I quickly learned that the US is, in the healthcare sense, should be seen as kind of a laboratory and a lot of experimentation, and in that sense there might be certain things one could maybe even learn even for a different setting that has a universal publicly financed healthcare system. But if going to your specific question, I looked at kind of a very specific development in the US, and that's the kind of increased adoption of what we call high deductible health plans. So in the US, a lot of people have health insurance, have private health insurance, and the most common type of private health insurance now are these high deductible health plans, and these have relatively low premiums, so it kind of might be more affordable from month to month. But on the other hand, when you need access to healthcare, you need to pay more out of pockets because there is quite a high ceiling before people actually get their expenses covered. And there's been increase because employers, many in the US, US students might know this already, but I want to give some background anyway. US employers increasingly provide high deductible health plans to their employees because that's presumably that's a cheaper way of providing health insurance. So what's then happened is that there are certain people who might need healthcare more often than others. So obviously, if you're healthy, a high deductible health plan might be a reasonable option. You pay low premium and you don't really get any other expenses. But some employees might have a condition, like some chronic condition, where you actually need to use healthcare more often, or you might have, more prone to get some complication that kind of requires attention. And if you're under a high deductible health plan, you might actually delay care because you might not want to pay, and you want to save yourself from paying that expense. You might try to delay healthcare, and that might lead to more severe complication. So my mentor had done research on the effect of high deductible health plans on patients with diabetes, and found that diabetes patients on these plans compared to those who are on traditional plans had higher rate of emergency department visits, kind of a sign that they might be delaying care and ending up with more severe conditions in the ED. So I also looked at this in a population with chronic obstructive pulmonary disease, and found that they also the people who were on these kinds of plans used healthcare less. Now we actually, because I experienced some delays with this work after the pandemic, so we actually still doing analysis on this, so I can't reveal everything on my findings actually here. But your bigger point, I think I can reply. You asked me how financing systems influence prevention. I think this is a case where, because the idea behind these plans is that the people might think more carefully about when they need healthcare, and you can lower costs. But when you're affected by some form of disease or have a chronic condition, you either delay and end up in the healthcare system anyway, and incur higher cost, or you get worse health outcomes, which seems to be the main finding when you look at people with different diseases. So I think how a health system is financed definitely does influence prevention access, and they might look very differently for different types of populations.
That is so interesting. First of all, it's so interesting that you studied the US and we're talking about global health. And in global health, people never talk about studying the US in that same way. I mean, I just don't encounter it. So that as a overarching topic is fascinating. But also I want to just highlight this for students that this is pretty interesting. And like I am, because I was a student for so long and different programs as a student or as a Fulbright fellow, I got assigned my insurance. I had one option. But now as a professional, I really encountered the same thing you're talking about. I had to choose between this high deductible where I could pay less every month, which, okay, that sounds great. But then there's so many other options and it's kind of overwhelming. And it also has big implications for what if something happens, if you don't have something that you deal with every day, like you said. So most students that I interact with are below 27 years old, and here you can still be on your parents' insurance. So like for me, I'm not pushed until I was almost 30 to have to think about this and make those questions, which is kind of late in life to be first prompted to think about it. And we don't have any part of the public health undergraduate, which curriculum that discusses insurance schemes, which is really, really interesting because like you said, it predicts or explains people's choices in disease prevention or self-care or accessing healthcare. So that's fascinating. So much to talk about there.
Yeah.
But we're having so much time on these questions. I want to get to the next question.
Sure.
So the next question, thank you, is about fair decisions and community input when financing healthcare. So back still on financing. So after returning from the US, you took on the leadership of a collaborative project with the World Bank focused on fairness and healthcare financing decisions. You have also led and are involved with research projects focused on public participation and community input to health policy decisions. What have you learned about how national healthcare leaders and policymakers make fair decisions about how to finance healthcare? Why does community input matter, and what kinds of changes can it bring to real world policy and equity? And don't feel that you have to repeat yourself what you said before about policymakers sometimes focus on what's in the news or what's garnering attention now.
Sure. Yeah, this was back. I was back in here in Norway in autumn of 2019, and our department got a project on, it was called the procedural fairness of health financing, and it's the goal was to kind of. Is it
published? Is that project published?
Yeah, everything is published.
I will link that. I will link that for the students.
Great. So basically, it was really about fairness when making decisions about how healthcare is financed, or for other matters in healthcare, can be understood in kind of two different ways. One is fairness in terms of kind of the outcome. So are you kind of making decisions that benefit people who otherwise face some form of disadvantage? And second is fairness from a more procedural point of view. Like, is the decision-making process treating people with respect and kind of valuing their input, and are these processes accessible to people affected by decisions? And the first point on what's called substantive fairness has, there's a huge literature on priority setting in healthcare, and yes, the students can look into that. Our work was on the procedural fairness, so it was trying to understand when national healthcare leaders, policymakers, and those who support them make decisions about financing healthcare, how can they design these processes to kind of fulfill requirements of procedure fairness? thinking that that's important for getting acceptance for these kinds of decisions. Because for many decisions in healthcare systems, you get, you can call it winners and losers. Some people gain and some people lose out, and we kind of need, for big decisions in the healthcare system, we need some form of public acceptance, even if you might disagree with some of the decisions. The health system needs to move on, and we need to kind of continue developing our health system together. So our thinking was that defining how these decisions can be procedurally fair is useful, because then to some extent people might maybe accept a decision about the funding of healthcare more if decision makers have been transparent, if they've shown that they try to inform the decisions with the best evidence, if they have taken into account public input and explain how that input has been used, and actually just justified why a decision has been made in a certain way. Now, there are a lot of issues around thinking about this. One might have, corrupt decision makers that kind of put in place a procedurally fair process to justify a very bad outcome. So those things, I think we could have discussed here, but it's beyond the scope, I think, of this conversation. So, but we went out to produce so first we produced a World Bank report.
Make you look great for your age, or maybe even.
So sorry. Sorry about that.
That's fine. And then we also had a series of case studies that's published in Health Policy and Planning, where we looked at actual decisions that have been made and tried to analyze those in terms of this framework that we created. So could be students are more interested in these questions, they can look into that, and there they will also see concrete examples of how community input was actually used for the important decisions in healthcare and why it brings value to policy and equity. And one way it brings value, bring value, is that community-based input can bring forward the interests and experience of people who might struggle to access these types of decision-making forums. Yeah.
So much great information there. I want to just be conscious of time and move us forward.
Sure.
Thank you so much for that. This is the last content question, is about researching the effectiveness of infection control measures. So now at the Norwegian Institute of Public Health, you're currently part of a research center called the Center for Epidemic Interventions Research. Can you tell us about what your role is and what kind of research your center is doing?
Yeah. So I'm a senior scientist here in the center, and in part I contribute to the planning and design of randomized trials, so studies of the effectiveness of different kinds of infection control measures, and these were the motivation for creating the center was the COVID-19 pandemic, where a lot of different measures were put in place without really knowing whether they work so well, both in terms of reducing transmission, but whether the benefit in terms of reduced transmission actually outweigh the potential harms. For example, the different measures that were put in school. And yeah, we could have a big conversation, because I think this looked very differently in Norway versus the US, and it's actually been quite a polarized debate, I know. So, but our center is dedicated to doing trials of these kinds of measures to generate more evidence, both in terms of knowing better what interventions might work in a future pandemic, but also preparing ourselves for doing such trials during a pandemic. And just to give you a very concrete example is that our center, our colleague here was leading a trial on air purification in classrooms. That's a randomized trial where a group of schools have been recruited, and half of them are randomized to receive air purifiers, and others are not. And then we will look at the effect on
I'm interested in what you're going to find.
Yeah, and whether they are effective in reducing transmission of respiratory infections. The outcome we're looking at is student absenteeism, because that's the most complete data we can get. So yeah, and we're also doing things around absenteeism. Yeah.
Absenteeism. Yeah. Oh, okay. Wow, that's an interesting indicator to look at.
Yeah, so we do that, and we're also working with the World Health Organization on developing protocols that can be rolled out during a future pandemic. So this is an area where we're both working nationally, doing trials here, regionally with our Nordic colleagues, and also at European level, and globally with WHO. It kind of extends all the way and kind of underscores my, I think, first point about thinking about global health as something where we can actually do work on questions that has universal value. And I think that's kind of maybe the main reason why I'm very motivated.
I'm going to quote you on that. I really like that. Universal values. I really love that. So the last question is just, I close every interview with advice for students. So with the sector changing so much, global health sector, from financing to stakeholders and more, what skills would you advise people who are currently learning about global health, people who are currently students, to focus on building now to prepare for a career in global health or a public health career? And what other suggestions might you have for them?
Yeah, sure. I'm happy to share some thoughts on that. I think from listening to our conversation, I think people might have heard that I've been working across very different issues, and I think that comes from, because I have a kind of a non-classical introduction to the field. That my PhD is on kind of laboratory sciences, study meningococcal disease, and then I kind of transition to more health systems and public health later. And I think, really being passionate and finding something you can be passionate about and really motivates you to spend a lot of time on it is the kind of best advice. That could be that you might be interested in a particular disease, I don't know, HIV/AIDS, malaria, reproductive, or a specific area like reproductive health. It could be that you're very interested in a specific type of research method and acquiring skills and developing those skills. Those skills are often transferable to helping support studying different kinds of questions. So one is to really find something that you're passionate about, but also not fearing that will lock yourself in. That knowing that those probably you can pivot to other areas later, and actually having kind of a sound foundation in one area actually can help you with moving to another. Actually, I think people sometimes think in reverse, that it's good to kind of have some experience in a lot of different areas. I kind of think otherwise. I think it might be better to find a few things you're passionate about, dedicate yourself in those for some time, and then maybe you might interest might shift, and that's fine. And you can find ways of applying your skills to a different question. And especially in this age where access to resources, teaching, skills things can be acquired quite fast. It's hard to not speak about AI these days, and I think AI-based tools is here to stay. So, experimenting and trying to take advantage of that without losing the importance of critical thinking. Yeah. So don't give your autonomy to AI, but still use them, use them to support you in your work. Yeah. I'll stop there.
I will link I really resonate with the first thing you said, and there's a book called Why Generalists Triumph in a Specialized World, and it makes the case for, it's very straightforward language book, and it really makes the case through so many examples of people who were innovators across different fields, that they pulled skills from their diverse backgrounds to create something new, or to think in a more critical thinking, creative way they were able to address problems. And that was more beneficial than having just done the same thing. And that really resonated because I'm like, oh, I'm like that too. I hope I didn't lose any of my momentum because I jumped from a few different topics that I was passionate about.
Yeah.
So I'll link that book for people who might be interested. And then to your second point, yes, we have a open AI policy in my classes, and I have a lot of tools or documents to encourage students to be very critical about what they put, and that unfortunately it can be easy to take this tool and have it replace your own voice, or to get mistakes included that become your own inadvertently.
Yeah.
And we have to be really critical of what we produce as writers or students or professionals, and also what we ingest. So, but these are, I totally agree with you, tools that's probably not going away anytime soon or ever. So might as well learn it.
Yeah, I think so too. Yeah.
Well, thank you so much for your time, Unni. I wasn't sure if we would get to enough time, and we've gone way over time. So I really appreciate it. And I will say thank you and goodbye.
Thank you for having me, and best luck to your students and yourself for your efforts going forward. Thank you.